Going to move on to some of our next sessions now. And we actually have two sessions running in parallel coming up next. In the first summit discussion panel, which will be broadcast on this same channel, we'll hear 3 in-country examples on the role that research can play in the design and delivery of more equitable cancer policy and programmes. The second session is a deep dive organised by Sanofi, which will focus on investing in the future, advancing age-inclusive cancer care. Now, to watch this session, you need to go to the main menu and click on the Live Deep Dive Session tab at the top. You'll also be able to ask questions during the panel by using the live question chat box. Just a reminder, all Summit sessions will of course be available on demand on the Summit platform in the digital library for 3 months, and that will happen very shortly after they've actually taken place live. Now, so for this first Summit discussion panel, I'm joined by Dr. Kate Allen, Executive Director for Science and Public Affairs at the World Cancer Research Fund International. Welcome, Dr. Allen. Dr. Allen is joined by Dr. Folakemi Odedina, Associate Director at the Centre for Health Equity and Community Engagement Research, Site Director in Florida and Director of the Global Health Equity Programme at Mayo Clinic. Welcome, Odedina. That is quite a title, and I hope I don't have to say it again. Our third panellist is Dr. Craig Earle, Vice President at the Canadian Partnership Against Cancer, a far simpler title. It makes you no less qualified, though, to join this panel, so thank you. I'm going to start with a few questions to each panellist and then close it with a live Q&A with our virtual audience. That's you. So, of course, we invite you, the connected leaders, to ask all of your questions to our panellists in the dedicated question box on the platform. So we'll start off this panel with Dr. Kate Allen. Kate, a focus of the World Cancer Research Fund International is on cancer prevention and through your work on risk factors in particular. Can you talk us through what exactly that work entails then?
Yeah, thank you, and good to be here. So we heard just now actually from Elizabeth about the fact that many cancers are very preventable. And after not smoking, some of the most important modifiable risk factors are around diet, overweight, obesity, and physical activity. And those are the factors that World Cancer Research Fund focuses on. And one of the ways we do that is through something called our Continuous Update Project, or CUP. So the CUP is like a global analysis and interpretation program. It has at its core a database which is housed at Imperial College London. And it basically captures all the evidence that comes out around those risk factors of food, nutrition, physical activity, and cancer. And there might be hundreds or even thousands of papers that come out in a year. So one of the aims of the CUP is to kind of keep on top of that and try and make a coherent picture of all of that disparate information. So we have an expert panel, they come along, they interpret the information, and they use that to derive cancer prevention recommendations. So there are 10 recommendations, and they were last updated in 2018. And we know from independent studies that in a real world setting, the recommendations reduce people's risk not just of cancer, but other NCDs because of the shared risk factors. So through our policy work, we then work to support the implementation of policies that will help people to follow the cancer prevention recommendations. So those recommendations have been a kind of raison d'etre of the CUP. But it's now also moving into a new phase, a new kind of exciting, innovative phase. So it's moving away a bit from this top line, one size fits all approach to a more kind of tailored approach. So it's also going to wrap in, for example, a cancer survivor angle. So we hope that we'll be able to provide guidance and recommendations for different cancer types, for childhood cancer survivors, for adult cancer survivors, and for different periods of time across a person's life when there are potentially opportunities to intervene to reduce cancer risk down the line.
I just want to pick you up on the point there about the CUP, the Continuous Update Project, informing new policy recommendations, as you just mentioned. How will that work exactly?
Well, it's difficult to kind of preempt what the CUP will come out with, because it's literally, the new phase is literally just getting off the ground. But for example, one aspect that we'll be looking at is applying a kind of life course lens. So looking at kind of infancy, childhood, adolescence, and also young adulthood. So it's possible that, for example, guidance that comes out around infancy could inform the development of feeding programs and nutritional guidelines for pregnant women and babies, because we know that larger babies are more likely to be at risk of overweight and obesity and therefore cancer down the line, but smaller babies are more likely to be at risk of heart disease. So it's a question of kind of not too big, not too small. Although we recognise that association, we don't know what underpins it, so we don't know what the mechanisms are. So I'd hope that the CUP would help to inform that, show more understanding of the mechanisms, and that could then translate through to guide policy interventions.
So would the CUP then also provide a sort of an insight into the critical windows that are necessary to sort of open and take a look through in order to influence cancer risk? And if that is the case, that the CUP does influence critical windows, how can we ensure that that message gets out not just to cancer patients and the cancer community, but also to the worried well, as it were?
Yeah, I mean, I think it's important to say as well that it's never too early and it's never too late for cancer prevention. It really isn't. It doesn't matter how old you are, how young you are, but it is true that there are kind of critical windows, as I mentioned earlier, that particularly can reduce cancer risk. So I think that what the CUP outputs are likely to do is to kind of translate through into a more kind of stratified approach to policy, a more personalised approach to prevention, in the same way that we have a more personalised approach to medicine. And that's already happening with prevention. So I would imagine that the results of the CUP in the future will kind of translate through into this more personalised approach. So we could, for example, see guidance around nutrition according to men, women, different stages across the life course and so on.
And one final question to you, Dr. Allen. I'm wondering how the scientific recommendations can be translated then into policy guidance that actually responds to the realities and the needs of those who are more vulnerable or the socially disadvantaged groups as well. And I'm not just talking about sort of low middle income countries as well, but I'm talking about populations within high income countries actually, who are chronically underserved.
Yeah, I mean, that's a very good question. And, we know that people who are from disadvantaged backgrounds are more likely to be exposed to risk factors, more likely to be diagnosed late, more likely to have problems accessing healthcare systems, and more likely to have poorer outcomes. And so those inequities persist across the cancer continuum. You don't sort of gain ground halfway through. It's a continual issue. So just actually today or yesterday, a new report came out within the UK showing that in England, for example, if the health outcomes of those from the most disadvantaged backgrounds were levelled up to match those from the best backgrounds, there could be something like hundreds of thousands less children who are overweight or obese during in England. And also a report came out just recently showing that in the most deprived areas, there is something like an extra 30,000 cancer cases. This is in the UK, a very wealthy nation. Something that we do at a local level from WCF UK, for example. Oh, excuse me.
Oh,
sorry, that's a lighting system cutting in.
Oh, that's okay. You handled it beautifully.
Sorry, it's trying to keep me physically active. So in the UK, for example, one thing that we do is go out to communities in East London, so Tower Hamlets, Hackney. These are areas in East London that have the highest levels of child obesity, poverty, inequalities. So we reach them through community programs that draw attention to our children's programs, which target not just children, but parents and teachers. In the northeast of the UK, which has some of the worst incidence rates in the country, and also survival rate, we actually deliver cookery programs, cookery classes to cancer survivors. And with health professionals, we engage a lot. We've recently done some work with health professionals focusing on breast cancer with an inequalities lens that highlights how women in the UK from particular backgrounds, for example, Black or South Asian backgrounds, have problems accessing cancer services. Okay. So although those examples are they're very far away from the heavyweight technical research of the CUP, of course, they're informed by the outputs and underpin cancer prevention recommendations.
Absolutely. Well, Kate, stay with us because we're going to get to the your fellow panelists and then come back for a Q&A session at the end. But thank you very much indeed. I want to now just move on to Dr. Odedina. Folakemi Odedina, thank you very much for joining us. I know you're passionate about health equity and have been working for many years on disparities I understand in prostate cancer in particular across the Black diaspora. So tell us about your research. Why have you been looking specifically at cancer outcomes among Black populations globally?
Thank you so much, Hannah, and it is such a great pleasure to be here. First, I'd like to just sort of add one more title to what you have read, which I think is important to understand, which is the fact that I am currently the chair of the research committee for the African Organization for Research and Training in Cancer, which allows us to really delve into the issues that you have just raised. So a little bit about the kind of research that I do. First of all, I am somebody that you call a translational behavioral scientist, which is I simply conduct behavioral research across the translational continuum to be able to test behavioral models, confirm who will benefit from those interventions, and to also be able to effectively deliver those interventions. Now, for the past almost 30 years, I've been working in the area of health disparities in racial and ethnic minorities and underserved communities in the United States. But for about 15 years now, I've also added the focus on global health disparities, working in low and middle income countries, especially in Africa. So you asked the question of why focus on Black populations globally. First of all, coming from a very disadvantaged background myself and being an African Black woman, my career goal when I started off in research was to move the needle relative to the health disparities that I see in our communities, in Africa, as well as in our communities in the United States as well. So earlier on in my career, although I focused on prostate cancer in the US Black men, but my career trajectory kind of changed. When a US Black prostate cancer survivor actually asked us the question in 2005, whether there is prostate cancer that is experienced by African Blacks as well, because it's such a huge problem around the US Black men. At that time, we didn't know the answer. So I decided to take a sabbatical, received the Fulbright Scholar Award, spent 6 months in Nigeria, and founded the Prostate Cancer Transatlantic Consortium that we call the CAPTC. And since that time, in 2004, 2005, we have continued to look at the disparities in prostate cancer among Black men globally.
And then with respect to improving prostate cancer outcomes then, what's working well, particularly in low-income countries, low-resource countries, what have you seen actually kind of having real, tangible benefits?
Yeah, so thank you for that. I've been, like I said, I've been working in low resource countries now for over 15 years. I just want to first of all say I do have a lot of respect for my colleagues, especially the ones in Africa. They are hardworking, intelligent, passionate in eliminating cancer in Africa, and they do it under significant duress in being able to do it. There are significant challenges that people face in caring for patients and making sure that they conduct research at the same time. One things that I have seen that have really, really made a major impact that I think is moving the needle the most is evidence-based medicine that is based on translational research, including clinical trials. And this is why we really need to focus more on this in underserved communities. So for example, there are multiple predictive models that our consortium has really developed to look at what is associated with prostate cancer care outcomes in Black men, including the social determinants of health factors, prostate cancer care and survivorship factors, as well as biological factors. For example, chronic inflammation and stress response. I am really, really excited about the rise of cancer genomic studies in Africa towards the use of precision medicine. With these genetic studies, we are now moving towards understanding what really drives the development and growth of different cancer in the African population. So this area of work, being led, in Africa is really, really very important. So I'll give you a clear example of something that has worked. One example is looking at the role of vitamin D in prostate cancer, right? And studies have shown that the risk of cancer mortality, is really high with vitamin D with reduced vitamin D supplementation. This is very crucial for Black men because the melanin that we have absorbs the sunlight and it prevents us from vitamin D formulation. So we are now working together with groups of Mayo Clinic investigators for us to be able to launch a vitamin D clinical trials that will study immunological effects of vitamin D replacement among African prostate cancer patients compared to the US Black prostate cancer patients as well. This is a clear example of us taking a look at what can we really do that is going to be cost efficient, but would impact prostate cancer in LMICs, as well as in underserved populations in high-income countries.
Okay, so I know that there are going to be questions because I can see them already coming in. More questions to you from the audience as well. It's fascinating what you're saying. Final question from me then is how can we use the research that you've just talked about to remove all of the disparities in care? Are there already some examples where this has worked really well?
Yes. So, first of all, I'm going to answer that question in two forms, because when we talk about research, we cannot leave out diversity, inclusion, and representation in science and innovation. And I think this is where sometimes that we miss the boat. If there's no representation, because people who come from those communities that are underserved, that are underrepresented, they are oftentimes the ones that have lived in experiences and are able to say, this is what we need to focus on. So unfortunately, we are still lacking representation in science and innovation in biomedical research. And there are some certain populations that are underrepresented in science and innovations. This comes with really unique challenges. So I'm going to answer your questions in two parts because we cannot get to this research without addressing diversity and inclusion and representation in science and innovation, right? So when we think about the challenges that we have, they include that they have personal challenges relative to this underserved communities and underrepresented minorities being able to work in the area of research. They also face country-wide, country-specific challenges, institutional challenges, funding challenges, and yes, I'm going to go there. Especially in low-resource countries, they also face the challenges of vampire science and helicopter science, where they are taken advantage of by investigators from high-resource countries. At a personal level, there's always the challenge of economic hardships. There's the challenge of not having role models. There's also the challenge of not having inadequate monitoring and insufficient population. We are raising really a cadre of scientists who do not have adequate mentoring, and we need to address that. At the institutional level, there's so many challenges in supporting investigators in biomedical research. And there is also, within United States and outside United States, there's the challenges of systemic racism, discrimination, explicit bias, implicit bias that really are hampering the ability for us to do the research that we need to do. And also, one of the things that is very difficult for people who are from these communities that are already underrepresented is the idea of funding. They are not even able to support the funding. And this, for our colleagues in low-resource countries, especially African countries, really is compounded by the fact that they are often taken advantage of by investigators from high-income countries, and they're really not able to do what they do. So that's the kind of challenge that I think we raise, and we really need to focus on being able to develop that. Relative to the 7 questions about unique examples, I gave the really clear examples of vitamin D trials on us looking at really low-hanging fruit for us to be able to address disparities. Another example I would like to, I'll stop if I don't.
No,
if I
no,
can
no.
go.
I don't want you to. Well, I might stop you just now because I fear that some of the questions, some of the points you're going to make are going to be answers to some of our questions.
Yeah.
So I know you're going to
Yeah.
stand by and come back for the Q&A session at the
Absolutely.
end. Thank you very much indeed, Folakemi. I'm going to bring in now Dr. Earle, who's in Canada as well. Welcome to you, Craig Earle. Wonderful to see you. Now, I understand that in 2019, your organisation, and we're talking here about the Canadian Partnership Against Cancer, you embarked on a really refreshing sort of update on the 2007 National Cancer Control Strategy. So what did you learn then from that process?
Well, we consulted with over 7,500 Canadians, health system leaders, physicians, charities, researchers, of course, cancer patients and their families. And we had facilitated sessions across the country. We did pop-up sessions in shopping malls, and we had an online tool where we asked questions such as, if you had $100 to spend in the cancer system, how much of it would you put towards prevention versus treatment versus palliative care, et cetera? But we knew from research that there are subpopulations within Canada that have worse outcomes. For example, Indigenous people, other racial and ethnic minorities, immigrants, sexual minorities, people who live in rural and remote areas. And so we wanted to make sure that we were deliberately targeting them. So we, for example, met with a gay and lesbian group in Montreal, or we met at an Indigenous community in Saskatchewan. And the online tool was also a bit of this strategy. And what we found is that for these populations, this is where the issue of access was the greatest, particularly in getting into the cancer system. They seem to have more barriers to getting that diagnostic test or seeing the specialist, as well as some of the care after cancer treatment.
So a lot of the research that you were doing then was sort of looking at addressing disparities in cancer outcomes among different populations, as you've just described. I'm wondering then how the results of that research then reflected, or that you know was reflected then in the strategy that you put forward as a result of it.
So we ended up making the overarching theme of the strategy is equitable access to quality cancer care for everyone in Canada. The strategy has 8 priorities, and 4 of them are the type of thing you'd usually expect in a strategy around prevention and screening and palliative care and survivorship, et cetera. But one of the priorities is specifically and explicitly about trying to remove barriers to care for vulnerable populations. And in addition, 3 of the 8 priorities are people-specific Indigenous priorities, things like culturally appropriate care closer to home, self-identified priorities in care, and Indigenous governed data and research systems.
And how then is this sort of new strategy influencing your work more broadly?
So we're calling our approach equity by design. If you look at health services research, there's a lot of evidence that when you introduce a new innovation into the healthcare system or the cancer care system, it can actually worsen disparities. So, for example, there was a study here in Ontario where when there was an expansion of PET and MRI scanning access, there was greater access for everyone, but it was most of the uptake was among wealthy urban population. And so if you look at the disparities, they actually worsened. And we're, of course, worried that with the pandemic and the shift to virtual care, that some of the same effect may be happening there. Because if you don't have a computer or access to high-speed internet, it's quite possible that you could be left behind. So what equity by design, what that means, for example, one of the priorities of the strategy is to get organized lung cancer screening programs up and running across the country. And so, for example, in the province of Saskatchewan, they're starting off doing that in the north of the province. Now that's where you have rural, remote, indigenous communities. It's where the smoking rates are higher, so it's where the need is actually the greatest, but it's not the easiest place to start a new program, a complex program like this. You would actually start it in the large cities in the south of the province. So by starting it where the need is greatest, even if it's more difficult, the idea is that it can't help but address some of these equity issues. Another example, we look at trying to eliminate barriers. When we were doing our consultations, we heard that access to clinical trials was a particular issue. If you don't live near a large urban cancer center, it's very difficult to access clinical trials. So we're supporting several projects trying to test the idea of having remote clinical trials where people can mostly stay in their community, but yet in partnership participate in a clinical trial at a major center, and in that way get access to innovative new treatments and remove barriers and address disparities. And I guess lastly, in terms of the Indigenous priorities, we're currently working with 29 Indigenous organizations in every province and territory across the country, working with them to develop their own strategies and priorities within the strategy. And so the challenge is going to be, as those come together over the next year or two, to make sure that we're able to address those self-determined priorities and again, address equity and disparities.
Okay, Dr. Earle, thank you very much indeed. I want to bring in your fellow panelists again now because we've still got a few more minutes to take some questions from our virtual audience, and the questions have been coming in thick and fast. So, Craig Earle, if I can stick with you just to start off with, just following off the back of what you've just been talking about. First question, how can we apply the lessons learned from the populations that you've just talked about to a more global level? Say, for example, the equity by design approach.
Well, I think, one of the major approaches that we've taken within our country, and I think could also impact things globally, is helping the jurisdiction develop a business case for taking this approach, showing why investment in decreasing disparities, serving the underserved first, can actually, in the long run, save funds or be cost effective. And that's something that can be difficult, even within Canada, for smaller jurisdictions to do on their own. And I think similarly, if you consider jurisdictions around the world. So it is one place where we're able to help and take a bit of a centralized approach in terms of making a bit of a global business case that then can be tailored to the specifics of a local jurisdiction.
Okay, thank you. Now, question to Dr. Odedina then. How can we better engage communities in research?
Oh, that's really a great question, because one of the things that we need to recognize is that there's absolutely no way that we can address health equity or we can eliminate health disparities without engaging the communities. And so one of the things that we do is research based on community engagement research. And that is the way that you really work hand in hand with communities, including cancer survivors as well as cancer advocates. So it is really very important that when we are also thinking about going into the community, we have to think very carefully in saying that you've seen one community, you really have seen one community. For us to be able to eliminate cancer disparities, we have to be precise in addressing the unique problems that are in the unique community. This is something that we are calling either precision public health or precision community health. Another thing that I want to emphasize is the fact that it is so important that a member of the community is part of the research team that you assemble to be able to do the work that you need to do. And finally, it is also important that you empower those from the community as well in different ways. And I will be happy to expatiate on how you can empower people that you work with in the communities.
Well, one more question to you, which is kind of related as well. Someone is congratulating you on the great point made on improving representation in science, which I think, Folakemi, that was your point. So how can the cancer community do better on this? How can it improve representation in science?
So when it comes to the challenges of representation in cancer and in the cancer community, there are multiple levels of why we have these issues. And so the issues have to be addressed at the multiple levels that we have them. So first of all is the individual level. Are we actually investing enough in those populations that really are disproportionately affected by cancer? Are we making sure that they are entering the biomedical workforce? Are we making sure that we have mentors for them? Are we making sure that we are providing all the tools and everything that they need to be able to do the work that they have? That's number one. Number two, at the level of the institution itself. I mean, within United States and outside United States, I've seen things that really is leading to quite a number of people who are underrepresented in science, actually leaving academia and leaving research. And those things have to do with the fact that they are often really have significant challenges and barriers from moving their career forward. And if you are unable to move your career forward, you really you can't do anything. From the level of not having the funding to be able to do their work to the level of discrimination, bias, and all those kind of things with the system. So I think it is going to take concerted effort by us stepping back and saying it is going to be a deliberate thing that we do. We are going to be deliberate in the way that we train, with the way that we have mentors. We are going to be deliberate in the way that we have representation, not only at the institutional level, at the funding agency level, at the society level, at the cancer community level. And we are going to be deliberate that not only are we recruiting them, but we are going to make sure we do everything to support and to retain them. Because sometimes a lot of us are recruited into institutions, cancer organization, cancer society organization, but there's nothing is done to make us feel welcome, to make us feel very comfortable. This is a topic I could discuss for years.
I can hear. I can hear that you could talk about it. I'm gonna have to stop you there because we have a number of other questions and a limited amount of time. Kate, I want to bring you into the conversation. Question to Dr. Allen: does the World Cancer Research Fund plan to include other topics in cancer prevention, such as an assessment of physical activity, stress, or sleep on cancer risk?
Yeah, that's an interesting question. The answer is yes. Traditionally, historically, we focused on the risk factors that I mentioned of overweight, physical inactivity, and diet, and that's been our kind of niche area. And there's still lots to learn in those areas. And although those factors to us seem kind of obvious, it's amazing how many people still don't recognise the links between those risk factors and cancer. But we do already, through our grant program, have fund research that does look at, for example, the impact of sleep cycles. We have been thinking about the area of kind of stress and cancer. So we are going to be looking at potentially expanding to some other areas as part of our strategic planning, actually, which is coming up soon. But we wouldn't cover all kind of areas like sun or radon exposure or things like that. So we would still have a sort of relatively small portfolio that we look across, but maybe a bit more expanded than now.
Great. And a question now to Craig, Dr. Craig Earle. Is there anything that you or CPAC would have done differently in doing your strategy? Would you go back and do anything in a slightly different way?
That's a very important question. And I think maybe while I think of an answer to it, one of the parts of the approach that I described was, I think, with that, based on that same idea, if we looked at the previous strategy, which was an excellent strategy from 2007, but I think the one thing that we recognized was that it hadn't involved as much consultation, and in particular, around the idea of self-identified and self-determined priorities. So, and I think this again is something that has a lot of meaning and extrapolation to thinking about global strategies for cancer control. The idea of speaking, for example, with First Nations, Inuit, and Métis communities, and coming up with ideas that, you know, care closer to home, care that's culturally appropriate, the importance of self-governed data and research strategies, et cetera, that the consultation and self-determination part is, I think, you know, one of the most important parts of this refresh strategy. So I guess where I'm leading to this is maybe doing even more of that, especially as we consider other, you know, Black Canadians, sexual minorities, et cetera. We did reach out to those, but even more next time, I think, is going to be the approach.
I think that's a very diplomatic answer as well. Thank you very much indeed. And my thanks actually to all three of our panellists and to our what has been a very interactive audience as well for sending in so many questions. I hope you have also enjoyed the live deep dive session led by Sanofi on investing in the future, advancing age-inclusive cancer care. Don't forget that shortly you will be able to watch all of the content on demand in the digital library on the Summit platform. That will be available then for 3 months. We are going to take a break now for 10 minutes or so. We'll be back at around 11:10 Boston time. That's 5:10 here in Geneva, so 15 minutes or so. During the break, we would, of course, invite you to connect with the Summit sponsors, check their profiles on the Summit platform. The Summit would not have been possible without their support. So thank you very much indeed, and I'll see you soon.